Ma'am, we are live now on YouTube.
Oh, okay. So, play the presentation. Okay. Done? Good evening, everyone. Welcome to yet another webinar by Nephrocon. Nephrocon has turned 2 this month, and we are grateful to all the nephropathologists and nephrologists who have participated over 2 years, and all the attendees who have supported this platform. We hope to continue to bring more such quality webinars for all our viewers in the upcoming days. So this month we will be discussing ANCA associated vasculitis. And for that we have Dr. Mahesh. He's a nephropathologist and head of department at Manipal Hospitals. And just before Sir begins, I'd like to put my inputs about ANCA with renal involvement. Everybody is aware of the Chapel Hill classification, and I think Dr. Mahesh will do better justice elaborating this and the histopathology, nephropathology of this topic. So, over to you, Dr. Mahesh. Sir, you can please share your slides now.
Okay.
Yeah.
Good evening to everyone. I'm Dr. Mahesh here. I'm practicing pathology here in Manipal Hospital, Bangalore. Thanks to Nephrocon, Dr. Purva and the team for having me here. The topic that is assigned is the ANCA mediated vasculitis and its renal damage. So as we go on to this, the definition of vasculitis, as the name suggests, it's inflammation of the vessel, and the inflammation could be affecting any of the vascular tree, as you can see here. Just now, Dr. Purva was mentioning about the Chapel Hill classification, and this is the pictorial diagram of a major vessel and its branches, the arteries, and that gives into the branch of arterioles, which connects into the capillary network, and then the venous side takes off. So the capillary level is the one which we are interested in for the today's topic. That's because the capillaries make the bed in the glomerular compartment, as well as in the medullary interstitium in the vascular network. So as you see here, that the images at the bottom, as you can see, that the inflammation is encroaching upon the vessel and it's destroying the vessel wall per se. And there are various diseases affecting the vasculature, and they are grouped into large vessel vasculitis, the medium vessel vasculitis, and the small vessel vasculitis. All that we see in the renal core biopsy is limited to the small vessels, because they are, as I said earlier, that the capillaries make the major chunk of glomerular compartment and the medullary interstitium, and the arterioles and the arteries are also sampled to some extent in the renal core. And so these are the ones which we get to see in the renal core labs. So the ANCA associated injury, as the full form of this ANCA is the anti-neutrophil cytoplasmic antibodies. So as the name suggests, the neutrophil is the cell which has these target the antigens in the azurophilic granules in the cytoplasm, to which the antibodies are formed. And these, when they come in contact with the endothelium of the vessel, they participate in along with the complements and the inciting agents. They destroy the vascular endothelium and cause the inflammation of the vessels. As it is purely a vasculitis of a small vessel, the clinical presentation ranges from across the departments in the clinical OPDs. The patient might end up lining up in a pulmonary medicine or in the ENT or in the gastrointestinal department or renal nephrology department. So the testing of this is done by either the immunofluorescence, indirect immunofluorescence, or by ELISA. And the group of lesions that are encountered because of this ANCA is the granulomatosis with polyangiitis, earlier referred to as veterinous granulomatosis. Nowadays, the term is omitted. And these could be a PR3 positive ANCA or a NPO positive ANCA. And in some instances, like up to 10 to 15% of cases, the ANCA serology might be negative. And the ANCA negative granulomatosis polyangiitis could be, from the clinical aspect, is more or less similar to how you see a seronegative lupus nephritis or a seronegative rheumatoid arthritis. So in that way, the serology would not be supporting you, but the histology would be showing you of that of a vasculitis coupled with the plus or minus the granuloma. And the second would be that of a microscopic polyangiitis, the Churg-Strauss syndrome, and the renal limited. It's only the renal system is being affected, sparing all the other organs. This being the fourth category. So looking into the pathogenesis of this ANCA-mediated damage. So as you see that these are the azurophilic granules which are there in the cytoplasm of the neutrophil. They are very well placed in the cytoplasm, but however, when there is inciting agent, these granules are moved towards the cell membrane, and these are primed because of the inciting agents, and the antibodies, the ANCA antibodies bind to these activated neutrophils, to which they release the reactive oxygen species. Sorry. So, and the proteases, and along with that, there is a damage of the vascular endothelium. So following this, there is the activation of the T cells and the monocytes because of the recruitment of these proteases, and the damage is further accentuated by the activation of the alternate pathway because of this. I'm sorry, give me a second. The complement system is being activated by the activation of this alternate pathway. Although the MAC is not the direct insult injurious in this scenario, it's the C5A, which becomes a vicious cycle of activating the leukotrienes, which are further accentuating this neutrophil to be in the primed status. So, how does this takes us to the question like the autoantibodies presence and the and the neutrophils that are primed, how it is linked to. So, in the pathogenesis, if we look at this, there are endogenous as well as exogenous inciting agents or the mimickers that for which the B cell forms the antibodies, and this would be taken care by our the immunity. But however, in case where the B cells are dysregulated, they permit the continuation of the autoantibody formation, and this is even helped by the Th17 cells, and thus there is the autoantibody formation which is in surplus, and the as I said before, the priming of the neutrophils which moves these antigens to the surface, following which these antibodies come and bind to this antigens. So how is this being tested in the lab? The ANCA detection techniques could be that of an indirect immunofluorescence, which is ethanol fixed, in which the ethanol fixed leukocytes are being tested. And this has a fairly high sensitivity of around 70 to 90%. But the more specific is that of a ELISA based, in which one can delineate that it is PR3 or the MPO, or even the other antigens like elastase, cathepsin G, azoxidine, lactoferrin, the lysozyme, and the PPI. So in the indirect immunofluorescence, these are the images for the C-ANCA and that of P-ANCA. So the P-ANCA starts, it is basically the perinuclear, that's how the nomenclature, it is P-ANCA, whereas the C-ANCA is more of a cytoplasmic positivity here that is seen, and that's the reason why it is called as a C-ANCA. So the predictive value for a Possiman crescentic gene, after having this result of the ANCA serology, this table shows the various combinations of the clinical presentation and the positive predictive value of it being a crescentic GN in the renal histology. So if we look at this, the presentation of a RPGN, and if the test is positive, then there is a likelihood of 95% turning out it to be crescentic GN. On the other hand, if the presentation is RPGN and the ANCA serology is negative, so that amounts to around 85%. It drops from 95 to 85. So mind you that the other 15% could be that of a ANCA negative Possiman crescentic GN. So if the presentation is hematuria and proteinuria with a less than 1.5 milligram of a serum creatinine, you see that the negative predictive value is almost 100%. So that gives us the importance of having this serology in to get it quickly and to initiate the therapy, because this is one of the critical alert in our practice in the nephropath, as well as sometimes these patients present with the pulmonary manifestations for which the management has to be quite fast. So going back to this Chapel Hill classification, as I said that this is more or less of a small vessel vasculitis. This yellow bar would give the range of the arteries, the vascular network that is affected in a small vessel vasculitis. So it can affect the capillaries, it can affect the arterioles and the arteries in the renal system. That that is sampled by a core, it can sometimes be seen even in the arcuate artery that is being sampled rarely. So if we look at this small vessel vasculitis based on the immunofluorescence, where the intensity of the positive reaction is less than 2 plus or a negative, that would be named as a posi immune reaction. And as mentioned earlier, it's categorized into three groups. The granulomas are the primary thing in case of GPA, and based on the serology of this ANCA, so the C ANCA is more of vaginous or the GPA, and the P ANCA is more in favor of MPA. In the clinical manifestation, these patients of Chuck Strauss would have tissue eosinophilia as well as peripheral eosinophilia, along with the allergic manifestations in the pulmonary symptomatology, along with the granulomas. So if we look at this chart, this gives us a fair idea about which of the ANCA the antibody is more common with particular disease. So if we look at this, the top one, which gives the table of the list of diseases associated with NPO, and the bottom is that of a PR3 ANCA. So if you see, the bulk of this PR3 is due to the GPA, and similarly the NPO ANCA is the bulk of it is due to microscopic polyangiitis. So these are the various positivity seen in these diseases. So you can see at the mid portion that there is a gap which is ANCA negative in all of these categories, and this category is further backed up with the renal histology of being a posi-immune, along with the non-proliferative necrotizing glomerulonephritis. The clinical features with that of ANCA specificity in the two categories of PR3 and the MPO ANCA, it's the demographics and the outcome, the relapse rate are the ones which have slight difference. Otherwise, the renal histology would be more or less same, with the presence or absence of the granulomas being more common in that of a PR3 ANCA category. So if you see the demographics, the NPO are slightly older in the age affected, and the relapse rate is lower in case of NPO ANCA serology, and the upper airway disease is also relatively less common in the MPO category. So coming to the renal histology, that this gives us the flow of from normal glomeruli to the focal proliferative. So the left-hand side, which is in the blue shade, is other presentation as highlighted in the bottom. All that we are concerned with the ANCA damage, usually they present with a rapidly progressive glomerulonephritis in the clinical syndromic presentation, and in the histology that would be that of a crescentic glomerulonephritis. So as it's everyone knows that the RPGN definition, it's an accelerated renal failure that's because of the glomerular destruction. So this should have been a non-proliferative. So it's an error here. And the loss of this renal function is over a period of 3 months, and that is being reflected in the urine as a very active sediments, and the presence of multisystem involvement would clinch the clinical or put the vasculitis at the top of the differential. So what is vasculitis? So vasculitis is basically the capillary walls that are being destroyed by the inflammatory cells, and in the sequelae there is a fibrinoid change of the destructed material. Here in this case, this is a glomerulus here, this being a vascular pole, and the capillaries here in this segment portion of this is being destroyed, and this is the hematoxylin and eosin stain. Whereas the same lesion that is seen in the meson trichrome, you would appreciate that this is more of a reddish in color, and the nature of this is fibrillar in character and not a homogeneous. In the silver stain, you would also appreciate that there is the break of these capillary walls in this tuft, and apart from the fibrinoid necrosis, having these nuclear debris amidst this fibrinoid degeneration. So following this destruction, there is a proliferation of this parietal epithelium, which is lining this Bowman's capsule to form a crescent that could be of partial in nature or a circumferential, as you see on your right hand side. How do I get this laser in this? So here, this is all the Bowman space that is being occupied by the proliferating parietal epithelium, which is partial in this Bowman's space, whereas the entire Bowman space is occupied by the cellular crescent, which is encroaching upon the underlying tuft. The aging of crescent is one thing which we need to keep in mind, because this is one of the finding that gives us insight into what kind of the etiology the renal damage could be of. The aging of crescents are cellular, fibrocellular, or a fibrous crescent. Based on this the composition, in a cellular crescent, it's more of a cells that is predominant. As you see here, the proportion or the composition of this crescent is more of a cells rather than the matrix in between. So more than 75% of the cells and less than 25% makes it as a cellular, whereas the fibrocellular crescent is a admixture of cells as well as a good amount of supporting tissue or the matrix material, as you see here. And on the silver stain, you can delineate the cells as well as the fibrous material. And you can also point out that there is hardly any Bowman's capsule surrounding this, that being completely destroyed. So in the fibrous crescent, it is the dominant composition of the crescent is that of a fibrous element or the matrix material with hardly any cells or the nuclei entangled in the matrix. So we'll go with a clinical history and the renal biopsy of one of the case, which belongs to that of an elderly woman who had presented with a sudden onset of oliguria, azotemia, and the hypertension. The routine urinalysis showed 2+ albumin with a plenty of RBCs, and the protein leak was 1.5 gram per day. The creatinine value was 7 milligram per deciliter, and the ANCA serology was positive for C-ANCA. So the presentation is RPGN and the ANCA is positive. So if we go with the table that I showed earlier, then the positive predictive value is almost 95% of it being a crescentic GL. So this was the renal histology, the low power magnification that shows around 7 to 8 glomeruli, and this magnification one can make out that there is definitely some abnormality in most of these gloms. So it's a diffuse process in this view. And as we go into the high magnification or the closest ones, you can see the range of abnormalities present in the glomerular compartment spanning the entire core here. So on the left top is what you see, the non-proliferative capillary walls, along with some leukocytoplastic findings in having these neutrophils, the debris, nuclear debris. But in addition, in other gloms, there is a tough necrotizing lesion here, destroying the capillary wall, the rupture of the capillary wall, and inciting reaction at the parietal epithelium. And in another glomerulus, there is more florid crescent formation compared to the previous one, whereas here the crescent formation is almost circumferential in nature. So this bottom middle glomerulus shows that there is tubularization of these crescents. The lumen formation within the crescents gives the terminology of tubularization of crescents. There were one or two glomeruli which absolutely look like a normal histology. So having the crescents and in combination with the normal set of gloms, as well as the uninvolved portion of the crescent bearing glomerulus having a non-proliferative nature, this almost tells us that this is a non-immune mediated crescentic glomerulonephritis. So meaning the immune category is not the insult in this case. So in the closest magnification or in the oil immersion, you can see that these silver stain highlighting the capillary wall, and it ends up abruptly, thereby giving a look of that these capillary walls are being ruptured. So in a sclerotic phase, this is how the glomerulus would look like, or where the entire glomerulus is being eaten up by the inflammatory reaction here. And in the silver stain, in HNE, this would be very tough to identify that this is a glomerulus. Whereas in the PAS or in the silver stain, the destroyed capillary walls or some remnants of these capillary network would be seen. And as I said earlier, that these are the fibrous crescents, how it looks like. Moving on to the tubulointerstitial compartment in this case, so the necrotizing lesions are also seen in the interstitium, and the inflammatory reaction is usually dominated by the plasma cells in cases of ANCA-mediated renal injury. The granuloma formation can also be seen in almost 20% of these crescentic GNs. The 20% depends on how vigorously the step serial sections are being taken. If there are centers where the step serial sections are taken up to the number of 16, then the likelihood of finding a granuloma is lesser. Whereas we here take the step serial sections almost 32 to 40 step serial sections, then in that case, the probability of having the granuloma is increased. Here you can see a granuloma and also the inflammatory reaction in the vessel, which is surrounded by the giant cell as well as the epithelioid cell collection at the periphery of this vessel. So as I said, in the Chapel-Hill classification, the small vessel vasculitis can affect in the extraglomerular compartment in the arteries that you see here on the left side, or the arterioles where there is hardly any muscle layer in the vasculature. and you can see that these neutrophils are adhering to this vessel at the periphery. In the medullary region, I'll come to this picture in at the later slides in this. So this is a medullary tubules surrounding which there are these vasa recta, and the neutrophils are causing damage to the endothelium of this vasa recta. So the prime diagnosis of pauciimmune glomerulonephritis relies on the immunofluorescence. As you see here, this is the glomerular compartment, and with various antisera that we deploy in the renal pathology practice, which includes IgG, IgM, complements like C3 and C1q, and the fibrinogen is optional. Along with the kappa and lambda light chains. So none of these antisera are lighting up in these glomerular compartment, whereas the fibrinogen is highlighting the portion of where the crescent is being formed. The underlying capillary walls are completely negative with the fibrinogen. So the pauciimmune is introduced, it is defined as the intensity of the positive reaction of less than 2. Anything which is equal to that of 2 intensity and the above is given a positive reaction, whereas lesser than this is called as a pauciimmune or a negative reaction. In certain scenarios, the adequacy becomes a very major issue, and the core that is sent for the light microscopy may not have the finding of an extraglomerular vasculitis. As you see here, this is a core which is sent for immunofluorescence, and we usually do routine the hematoxylin and eosin stain on the core that is sent for the immunofluorescence as well. This shows the fibrinoid change of the vessel wall along with the nuclear debris and the inflammatory reaction around it. And this highlights the fibrinogen in the fibrinoid areas. So this is very important finding which one should carefully look into in the immunofluorescence core, which has a very important what should I say, like the management decision when it comes to a case of anti-GBM along with the ANCA-mediated combined double positive vasculitis. So the renal prognostication is more based on this article, which we follow it across the globe, and this introducing of the classification of this burdens way of approach has given a more prognostic value to the categorization of the crescentic glomerulonephritis. That is based on how many of the gloms in the given core are normal. I mean, if the in a sample, like say for example, if there are 20 gloms in a core and more than 10 gloms are normal, then it is grouped as focal. And if there are more than 10 gloms which have a crescent, be it a partial or a circumferential, then it is grouped as crescentic class. And if there are mix of lesions and there is no majority in any of these group, then it is group called as a mixed class. And if more than 50% of the sample glomeruli are sclerotic or a fibrous crescents, then it is called as a sclerotic class. So this classification is backed up with the follow-up details of these patients over the 1 year survival and almost 10 years, I should say, in this article, which has given prognosis of being very good in the class of focal, that the meaning more than 50% of the glands are unaffected and they are normal in the core. The second good prognosis is that of acrocentric and followed by the mixed category, and the sclerotic is the one which has a downhill course of renal survival. So moving on to the prognosis of the center portion in that ANCA positive versus ANCA negative. This article and others have also validated that the ANCA negative Possiman glomerular nephritis behaves poorer than the ANCA positive GN. As you see here in the various lesions, the glomerular lesions and the interstitial fibrosis, especially this interstitial fibrosis is diffuse, and the dominant finding in cases of ANCA negative, and thus it has a very poor prognosis compared to the ANCA positive ones. So in the renal histology, when we screen the cases, what are the points, or when do we have to suspect the ANCA crescentic GN? The positive predictive value of it turning out to be ANCA is when we see a pleomorphism of crescents, meaning the aging of crescents spans from cellular to fibrocellular to fibrous. It just hints that the crescents, origin of these crescents are over a period of time, and it is not at a single point of time. And the second thing is to look for the glomerular tufts of the crescents bearing glomeruli as well as the non-crescentic glomeruli. So if the tufts are non-proliferative, then it is another favoring point for an ANCA-mediated lesion. And the interstitial findings, especially that of a granuloma and the inflammation that is rich in plasma cells, again favors. In the vasculature, if there is a transmural necrotizing arteritis, or if the medulla is being sampled, medullary tissue is there, to look for if there is any angiitis in the vasa recta. So these are the histologic points, and of course the clinician would have sent the ANCA serology in a case of rapidly progressive glomerulonephritis, and in the to stamp all these findings, it's the immunofluorescence which is the key diagnostic to say that it is a Possiman glomerulonephritis. The electron microscopy is of very little help. I should say that the EM can be done in the academic interest, and also to exclude if there is any confounding clinical presentation, or if there is any added histologic finding, to exclude other etiologies by electron microscopy. By and large, the EM has very little role in the ANCA-mediated injury. So the this table, which is taken from the Heptinstall book, it says about the percentage of the crescents in the given tissue and the etiologies associated with it. So before this, I forgot to mention that the crescentic GN, there are two schools of thoughts. So if there is a single glomerulus with a crescent, one school of thought mentions it as outrightly crescentic glomerulonephritis. But there is another school of thought having a percentage of glomeruli being affected by crescents, and that amounts to more than 50% of glomeruli having crescents. So if we go by that, the second school of thought, the percentage of crescents, it's very obvious that the crescentic GN, or more than 50% of the gloms having crescents, fall in these two categories. The one is the ANCA glomerulonephritis and the anti-GBM glomerulonephritis. If you can see that in the middle of this, the percentage of patients with 50% or more crescents. So the bulk of it belongs to these two etiologies, and the focal crescents. See here, the bulk would be that of a immune-mediated etiologies. So in that way, just by the look of crescents, the number of gloms with crescents, that would give a first look of what could be the etiology, the probability of whether it being immune-mediated or the other two limbs of ANCA or the anti-GBM, before you go on to the more depth details of the histology as well as the immunofluorescence.
So I'm sorry to interrupt. We have to have is it possible to
Sure,
we
this
have to
is
continue with the
another couple of slides. So in the sign notes, it's the percentage of the gloms and the aging of crescents. I've mentioned this earlier. The immunofluorescence becomes key, and the RPGN presentation, these are the three panels of immunofluorescence, how it looks like between immune complex or anti-GBM and the post-immune. And there's the post-immune would have this kind of angiitis in the medulla. This is one of the major article from the Arcanus lab, which mentions that medullary angiitis can be seen in ANCA associated and in certain fraction of IgA as well, and also secondary to antibiotic status. So a combination of ANCA mediated is seen with lupus nephritis or anti-GBM. And this is one of the case where I wanted to highlight the presence of extraglomerular necrotizing vasculitis in a case of anti-GBM. This definitely says that this is not just an anti-GBM. There is a component of ANCA mediated, just going by this capillary classification, because anti-GBM affects only the capillaries, whereas these arteries, which are proximal to this, are affected by the ANCA serology. So this is one of the mimicker which the pathologist would face difficulty in calling it as necrotizing lesion in this feeding arteriole, the preglomerular arteriole. So as you see here, this is a histology of a thrombotic microangiopathy where the fibrin is just limited to the vessel lumen without having any inflammatory reaction. Whereas the arteries have this the nuclear debris in the vessel wall, and the inflammatory reaction is quite significant. I would leave the last slide as on with a quiz to all the participants here. Which of these two images depict a true crescent? One is true that of a crescentic GN, and the other one is that of a collapsing GN. So you have to decide which among the two is that of a true crescent. With that, I end my presentation. It's over to you, Dr. Purva.
Thank you, sir. Is it A? I mean, just to close this quiz here. What is the answer to your question before we start with the panel discussion?
On the left-hand side that you saw, the necrotizing lesion was that of a true crescent, whereas on the right-hand side was that of a hyperproliferating podocytes. That's the collapsing FSGs, which is another critical alert in terms of our practice.
Right. So thank you so much, Mahesh sir, for such an elaborate pathology of ANCA vasculitis. And sir has covered quite a lot of points, so I think we'll just have to rush to the clinical aspect. This diagnosis of ANCA vasculitis, the nepropathologist has a very pivotal and extremely important role, because without that, treatment becomes a little difficult, and we can't hit with immunosuppression even if we are attracted to it, unless and until. But the KDIGO guidelines say that if at all you are suspecting vasculitis and you are waiting for the serology reports and the biopsy reports, you can start with the treatment. So, to that, we have two young dynamic experts to answer the questions on diagnosis and management of ANCA vasculitis with renal involvement. We have Dr. Nithyashree Nandagopal from Chennai and Dr. Vaibhav Keskar from Thane. I welcome you both to Nephrocon's anniversary forum on ANCA vasculitis. So the diagnosis of ANCA vasculitis can be a tough one, and more or less, a nephrologist is not the first person actually being the primary physician of the patient. They may have undergone extensive investigations, and it could be that after the individual develops some sort of a renal injury, they will call a nephrologist. And it may affect all age groups, but the incidence is peaks in 60 amongst the 60 to 70-year olds, and it has a male preponderance. So coming to the fact that everything has been done and now we have the biopsy in hand, I'd like to ask Dr. Mahesh sir, everything looks the same for an unskilled eye, like you've already taken a quiz for us. But if both, TMA and ANCA negative vasculitis can show fibrinoid necrosis, how should one differentiate between the two on biopsy?
One of the main finding that a necrotizing lesion would have is because of the fibrin and the inflammatory reaction, the nuclear debris would be the telltale sign of a vasculitis, which is not a common finding of a thrombotic microangiopathy. The thrombotic microangiopathy, if it is seen in the vessels, that would be fairly limited to the lumen without having any inflammatory reaction. That is one of the main findings that we bank on to delineate between a TMA versus necrotizing lesion.
Right. So, having neutrophils and probably the presence of crescents differentiates between a necrotizing GN and DNA.
And of course,
DNA.
in the special stains that you have that's on the screen in the middle, so this glomerulus is undoubtedly a necrotizing lesion with a crescent, and the difficult part is this artery having a fibrin thrombus or is it a vasculitis? So if you carefully look at this being a silver stain, and if there is a rupture of the elastic tissue here that is highlighted as a black or a jet black in color, there is a disruption of this vessel wall and some amount of nuclear debris, but the disruption of this elastic tissue, which is not a common finding of a thrombotic microangiopathy.
Right. So for us, I think we'll be able to reach that, okay, this is necrotizing GN. But I think the onus lies on the nephropathologist to delineate it between the two. And you were very beautifully explained it. Thank you for that. So coming to the part where the nephrologists are interested in, because prior to biopsy, we start sending ANCA serology, the PR3 and MPOs. And we have two commercially available tests, indirect immunofluorescence and ELISA. And the consensus report says that ELISA is a high quality immunoassay, and that should be done rather than the immunofluorescence assay. So I think most of the commercial labs, you have to be very meticulous about what methodology are you testing for getting serology of ANCA. So with that, I'd like to ask Dr. Nithyashree, do you prefer ANCA serology or biopsy, and what is the sequence while diagnosing ANCA vasculitis with renal involvement?
Yeah, to that, Purva, I'll answer it in two parts. I think it's not prefer one over the other. It goes hand in hand rather. So when there is a initial clinical suspicion, then we go ahead for the serology. And when the serology comes positive, then we definitely know we're dealing with something that is ANCA associated, damaging the kidney. We may initiate even steroid therapy without waiting for the biopsy report, because it's if somebody is presenting with rapidly progressive GN, it's a matter of time that we need to save starting treatment early is beneficial. But having said that, just a serology we will not probably go ahead with the full course of induction therapy with just the serology, because the histopathology offers so much more information in terms of prognosis also. What is the response to my treatment, and if is there underlying chronicity, which I'll be able to educate my patient further, and also set my treatment goals based on the pathology report that's available in front of me. So for a diagnosis and initiating treatment, I, without hesitation, when there's a clinical picture of crescentic GN and a positive ANCA, we'll initiate treatment. But how it's going to pan out, how I'm going to plan my induction or maintenance, depends on the biopsy report. So I think both would be required, and it's not like one over the other.
Right. The next question is, how does ANCA negative vasculitis differ from ANCA positive vasculitis in terms of diagnosis, treatment, and prognosis?
Yeah. So first is ANCA negative vasculitis. Yes, there will be some delay in coming to the conclusion that it is actually a crescentic GN, which can be ANCA negative. The reasons for the negativity can be there are atypical antigens against which these ANCAs are directed against. So there is a considerable delay in the diagnosis when it comes to ANCA negative versus ANCA positive, which is pretty straightforward. In terms of treatment, again, your response to treatment would be slightly not as expected in an ANCA negative GN, because like Dr. Mahesh had pointed out, there is considerable amount of interstitial fibrosis that is present in patients who have ANCA negative vasculitis. So obviously your response to treatment would also be that much poorer. And so because of this response is not so great, long-term prognosis for ANCA negative when compared to ANCA positive is also slightly lesser.
Right.
And they don't have systemic symptoms as much. The ANCA negatives are mostly renal limited from whatever we've seen.
Right. So we've already discussed that higher quality immunoassays are better. So coming to the next segment, because I have to rush, so will not spend a lot of time on each question. They occur in the background of a lot of other glomerular diseases. So that ANCA can occur in conjunction in overlapping anti-GBM, lupus, IgA, even the drugs like hydralazine, they can lead to an overlap syndrome. And there was a study in Korea wherein they did ANCA serology for 232 cases of systemic sclerosis, and almost majority of them had ANCA vasculitis. So they came to a conclusion that for every patient who has systemic sclerosis, you should also look for ANCA positivity, and that can help in the treatment and marking the prognosis of the patient. So I'd like to ask my first question to Dr. Vaibhav. How often do you see overlap syndromes with ANCA positivity, and does this alter management?
So mainly we see overlap syndrome, like double positivity in anti-GBM disease, and almost 20% of our anti-GBM antibody syndrome cases can have ANCA positivity. It's mainly anti-MPO in many cases, but the treatment here slightly differs, because with ANCA positivity coming in, these patients have higher risk of recurrences, relapses. And while in a run-of-the-mill anti-GBM case, we do not treat if they present requiring dialysis. It's not the case if ANCA is also positive. So the treatment is offered as if they are ANCA-associated vasculitis. These patients often, almost always, should be given maintenance treatment to prevent the relapses of ANCA. So this is the most common scenario we see. The other scenario I would like to mention is maybe false positive ANCA. sometimes we see anti-MPO positivity and p-ANCA positivity when ANA titer is very high. So this is one of the common scenarios where ANCA report is positive. But the lab can guide us if that's the case. Um, so, yeah, these are the common scenarios we see.
Do you monitor ANCA titers to assess activity or relapse?
So personally, I don't monitor ANCA titers to assess activity because the titers do not correlate well with the disease activity. They do not guide us about the duration of treatment or the agent that we choose for um, uh, maintenance or induction therapy. So even the titers do not preclude transplantation. So if a patient is 6 months to 1 year after the is on dialysis for 6 months to 1 year, and there are no signs of disease activity, either renal or extrarenal, and ANCAs are positive, that doesn't preclude transplantation. So monitoring ANCA titers does not tell us about the activity.
Right. So with that, we come with for the treatment and prognosis of ANCA vasculitis. In a nutshell, if there is no renal failure as such, rituximab and glucocorticoids work just fine. And if there's rapidly renal progressive failure, then we add plasma exchange and cyclophosphamide and other immunosuppression. Of course, maintenance we can do with rituxin, even the non-renal cases, and azathioprine and MMF and prednisolone have been used for maintenance after remission. But in life, things are not as per the text, and if it is gray, black and white, then things would have been a lot easier. But in that scenario, we have done plasma exchanges even when it is outside the textbook guidelines or outside the textbook indications. So I would like the discussion to have some emphasis on that also. And with that, I'd like to ask, what is your approach to managing vasculitis with or without rapidly progressive renal failure in your cases, Dr. Nitya?
Yeah, I think you've answered that question for me, Purva, just in the previous slide. So
But
like you
then I think
said,
I would like a more detailed, because everybody knows about this. So,
so primarily it's about, see, it is this antibody that is causing some organ injury, and the degree of organ injury dictates your intensity of immunosuppression that you choose. So that is the broad basis on which we choose our treatment. So like Dr. Mahesha pointed out, there is a very big clinical spectrum in which ANCA-associated vasculitis can present, ranging from no renal at all and only extrarenal, and in renal asymptomatic hematuриas to rapidly progressive GNs. So when last end of this spectrum is the rapidly progressive GN, which needs full and heightened immunosuppression, where we choose steroids and a cytotoxic agent or a B cell depleting agent. Preferably when there is a rapidly progressive glomerular nephritis, cyclophosphamide is the treatment that we go to. Although rituximab has also been shown as equal, I personally prefer cyclophosphamide who in somebody who has dialysis dependent renal failure as a result of crescentic GN. One, because the onset of action of rituximab is slightly slower, and the efficacy is also, although the safety profile is better, I feel cyclophosphamide as an cytotoxic induction agent fares better in these scenarios than rituximab. So my choice for somebody with rapidly progressive GN or a crescentic GN would be steroids with cyclophosphamide every fortnightly rather than rituximab. Plasma exchange, there are particular indications in which we do plasma exchange. So one would be when the ANCA is associated along with anti-GBM, then definitely we go for a plasma exchange. The second is if the degree of renal failure is very severe. We had the trials which says for and against plasma exchange, but generally we tend to try and throw in whatever we have. So when they're very dialysis dependent, then we go in for plasma exchange. And the third reason is if it's a extra renal one, like a pulmonary hemorrhage and patient is ventilator dependent, then to pull them out. These are the primary three indications where we throw in plasma exchange in addition to our cytotoxic agent. When there is no rapidly progressive renal failure or the renal failure is limited only with proteinuria or hematuria, I think rituximab with steroids would be a safer option because of the safety profile and the equal efficacy and the superior safety profile of rituximab. So this is primarily induction. And the maintenance, I think at the end of 6 months would be I'd go for azathioprine for both for a period of 2 years.
Right. I'd like your inputs on this question also, but I'd like to ask Dr. Weber first. Have you found plasma exchange beneficial in only cases with renal involvement, despite of the Pexiva's results where they do not advocate doing plasma exchange with only ANCA vasculitis limited to kidney disease?
Right, as Dr. Nitya rightly said, we like to throw in all we have. So we have seen recovery, but it's difficult to say if recovery would happen if we wouldn't have Plex stem. So typically, a dialysis requiring patient receives either cyclophosphamide or rituximab and also Plex. So we've seen patients discontinuing dialysis even though they were on dialysis for as long as 6 weeks, 8 weeks also. So there could be a delayed response. Although Pexiva's trial didn't support routine use of plasma exchange, the meta-analysis done by the same group, like a couple of years later, they published that meta-analysis. There was some indication that risk of end-stage renal disease would be less if patients receive plasma exchange. So we do use it, but it's difficult to know if what would happen if we don't use it.
Right. Dr. Nitya, I'd like your
I think
comments.
I completely agree with what Dr. Vaibhav said. I think we just do everything that we can, but what really made that difference was it just immunosuppression or the added-on plasma exchange is very difficult to tease out that difference. And I think, like he said, the subsequent meta-analysis which showed benefit. So what's the harm? What's the harm in trying to get somebody out of dialysis when they're really in bad shape? So
So how many,
personally, we'll
like
go.
before you say call it a day, how many plasma exchanges would you want to,
A rough guide is we go with five sessions, maybe three
Five.
back to back, and then 2 alternate days, and then mostly we see response in that. And I generally don't go more than that.
Okay. Dr. Vaibhav, your experience about how many plasma exchanges and what
Yeah,
should
so we go from 5 to 7 sessions,
right?
and after that we do continue maintenance induction therapy.
Mhm.
So we continue for up to 3 months. So at the end of 3 months, if they remain on dialysis, we start tapering, and then we back off and stop immunosuppression.
Right. So that brings me to the next question. When should immunosuppression be stopped? Either after recovery, when should you stop it? And if the patient is dialysis dependent, then you just completely stop it. And that is when? Like, when does
So,
that?
if someone is on dialysis on presentation or during the hospital course, we still have hopes that he or
Yeah.
she recovers. So, we continue therapy for 3 to 6 months. At the end of 3 months, if the patient is not recovering, then
Mhm.
probably it's time to back off and stop the therapy by 6 months. Uh, uh, but if there are other systems involved, for example, pulmonary hemorrhages, ENT involvement, then we continue the treatment as if they are not on dialysis. So the extrarenal disease still merits the treatment. The treatment drugs may be different. For example, we don't like cyclophosphamide much on dialysis. Of course, we can't use methotrexate in these cases, but yes, extrarenal disease needs treatment in such a case. What if they recover and do well, and then we continue maintenance therapy? So there are protocols like rituximab treatment is described for 18 months. But there was a trial where they did use azathioprine for 4 long years before they stopped. So the duration of treatment could be anywhere from 1.5 year to 4 years. And when we start tapering, we pay close attention to the clinical picture, urine proteinuria, hematuria, extrarenal activity, and then only we start tapering and stop it eventually.
Right. So that brings me to the next question. What factors predict better outcomes in post-immune crescentic GN with ANCA positivity? Dr. Nitya.
Yeah. So better outcomes in terms of post-immune, I think it's the rapidity of diagnosis and how early treatment is initiated. That is one thing. So see, when what is the antibody associated with this crescentic gene, whether it is a PR3 or an MPO. So if it's a PR3 antibody causing the crescentic gene, that has a better prognosis because it gets picked up that much faster. It does not have a remitting waxing waning course like the MPO ANCA associated vasculitis, and so its response to treatment is also better. So between the MPO and the PR3, those with PR3 have better outcomes. And the clinical presentation, again, when somebody's clinical presentation is dialysis dependence and there is some amount of chronicity on the biopsy by the time we get to it, then that is again a factor that is against better outcomes. Where if the histology is clean just with crescents and not a lot of chronicity, again the histology is something that will favor better outcomes if it has no chronicity, and younger age generally tend to do better. So young age, no chronicity on histology, and a PRA associated rather than an MPO associated are some of the factors that help in better outcomes.
Right. I think Dr. Vaibhav is a pediatric nephrologist, if I'm not wrong.
Yeah, I'm a pediatrician
Have you
basically who's
seen
trained
any
in.
any
Oh,
vasculitic cases in children?
it's very rare. I've seen a few. Basically, the treatment principles remain the same. The course could be quite aggressive, so but the principles remain the same. Principles of treatment remain the same.
Right. So with that, now that we have treated ANCA vasculitis, we come to the last segment wherein the patient has now come to end-stage renal disease and we transplant them. And I'd like to ask Dr. Vaibhav, how do you approach transplantation when the native disease was necrotizing vasculitis? Because we have to keep in mind that we don't know how to index the disease activity, especially when uh, vasculitis is in this form.
Yeah, if someone is on dialysis because of ANCA-associated vasculitis, we typically wait for 6 months to 12 months before we transplant them. The most important thing is there should not be any disease activity. Extrarenal disease should not be there. And of course, they should not have active renal disease either, which is difficult to know, but the hematuria and proteinuria may be surrogate pointers.
Right. And as you already said that
Even if they are ANCA
don't,
positive at that point of time, we go ahead.
yeah, titers
So
don't matter.
yeah.
So
So
any precautions you would take before transplant?
So we make sure that we have thorough evaluation to see the disease activity. We immunize them well in advance, and we transplant them like any other transplant, any other ESRD patient.
Right. So, Dr. Nitya, I'd like to ask, do you modify, if have you thought of modifying induction therapy, for instance, preferring Ritux over ATG or basiliximab in these cases?
No, no.
Right.
Personally, I don't think I'll modify my induction regimen based on the disease. I think induction regimen depends on the immunological risk of the particular patient. Of course, I will keep in mind the cumulative immunosuppression they've received over years before I choose my induction. But in terms of vasculitis, I don't think I'll prefer rituximab over ATG for my induction. ATG versus basiliximab depends on the immunological risk of that particular individual.
Right. There's one interesting case I'd like to highlight. So we have one anti-GBM disease presently under our treatment, and we did his titers, and they are still high, but we are not dependent on them. It's just that because he is having an ABO incompatible transplant, he is going to eventually undergo plasma exchange prior to transplantation. But let's say it's 6 months after the disease has been there since 6 months. Would you consider doing plasma exchange 1 or 2 sessions, 3 to 3 sessions prior to transplantation? If
Just
it was a ABO compatible kidney transplant.
No, because we waited enough in terms of ANCA vasculitis, you waited enough for the disease activity to die down. You're waiting for a period of at least 1 year with clinical quiescence. So, and the ANCA titers don't really predict any recurrence in the allograft. So, I had a patient of mine who was worked up for a transplant, was an IgA vasculitis. We didn't even look at him as an ANCA positive vasculitis, but for some reason he had hemolytic anemia, and I just did the ANCA, and his ANCA titers turned out to be very high. I waited for a while, gave him some MMF to see if the titers go down. It didn't, and I did go ahead with transplant because he didn't seem to have any form of renal disease or extra-renal disease. And he's 2 years into transplant now and does not have any recurrence. So I did not resort to plasma exchange. So I don't think it warrants for just the titers or the antibody removal. If there are extra other indications for plasma exchange, we can go ahead.
Right. So Dr. Vaibhav has already answered how long should we be waiting before transplant. Now, coming to the recurrence part, Dr. Vaibhav, how often have you seen recurrence of vasculitis in kidney allografts?
So 5 to 10% of patients who receive kidney transplantation have experienced recurrence after transplantation. And typically the transplant immunosuppression appears to protect against such recurrences. Whenever we see such recurrences, we try to treat them with either rituximab or cyclophosphamide. Yeah, so the recurrence doesn't mean that we are going to lose the graft. We can still be treating these patients and improving renal graft survival.
Right. So I think we've already discussed if anti-GBM antibody positivity has any impact on kidney transplant. The titers don't have any significance. And although we should have a clinical suspicion of recurrence, when would you want to screen for recurrence in these cases?
So we don't screen them routinely. If they have symptoms, we go ahead and we go for thorough evaluation. Of course, when they come for routine follow-ups, all of them have urine urinalysis done, urine protein creatinine ratio done at the intervals. So that's how we keep a watch. But we generally don't ask for ANCA titers on each visit.
Right. But I think if at all recurrences occurs, it probably will occur in the first few years of transplantation. And I don't know if it will occur later in life, probably say 5 years later or probably 7 years later. Not, I don't know about what the literature says. So with that, we come to our end of panel discussion. It has been a wonderful discussion. If there are any questions, I would just take a look. So nothing, no questions for panelists. So thank you so much, Dr. Mahesh sir, Dr. Nitya, Dr. Vaibhav for participating in our 2-year anniversary forum. It has been a wonderful experience, and I hope to have you on board in our future webinars as well. Thank you so much.
Thank
Are
you.
there any comments from your end which you'd like to have?
No comment. I mean, this has been very educative session. I have seen a couple of videos in the YouTube. That's really informative and also easy learning tool for all the nephrologists trainees as well as the nephropathologists trainees. It's a easy way of teaching, and it was.
Thank you. So I'd like everyone to subscribe to our channel and probably take a look at our previous videos. And I invite you all to join our group as well for informal discussions if there are any. It's a group of nephropathologists and nephrologists. We tend to discuss cases whenever we are stuck. So it comes handy. And thank you all.
Thank you.
Thank you very much. Good night.
Thank you.
Thank you.